Right. So, as a part of our SIG activity, although we have limited time, it is important to emphasize on what we can do to contribute to the transplant society, transplant activity in India, uh, contribute to the INSL, and how we can, sort of, amalgamate or coordinate with other important societies, LTSI. And I think me and Dr. Pamecha, we thought of a couple of points, and we then jotted out these points. We think that these are very important, not easy to answer. For example, we need to spread awareness about ideal timing and early referral for liver transplant in India. I'll enumerate them, and then we'll need the experts to comment. I think it's very difficult. Day in, day out, we see patients coming to us who are in, advanced stage of, multiple problems. They are, sick. They're in ICU, and mostly the ACLF3 patients. And then we are really bordering futility versus transplant. Then how to increase accessibility of liver transplant in India? Again, a very difficult thing. It's still a fact that only a selected population gets access to it. Others cannot because of various reasons. Financial is one of the topmost reasons. There are a lot of centers coming, more than 150 centers also. Is that the right way? Unlike, where the centers invest, where there's structured, specific centers which cater to a population. I don't know the answer to it, but it's an important point. I think which I'm going to have a talk today in the afternoon. I think Dr. Soin is in the session also. There is a thought which Dr. Pamecha was highlighting, that donor selection in living donor liver transplant in this MASLD era is not so easy, because almost 30-40% of patients have fatty liver. And we don't know what is the long-term implication of these donors. They do well in the initial part, but are we comfortable with them? For example, if there's a patient who had a 30%, 20% steatosis improved and had a donation, recipient is fine. What happens to the donor after 5 years, 10 years, 15 years? That donor did at 30 years of his donation, and then what's his life going to happen? What's going to happen to him at 50 years, 60 years? We don't know the answer to that. But I think that's something we need to think over. Specifically to the INSL task force which we want to develop, one is that we should promote the liver transplant training, which as hepatologists, we would say hepatologist or critical care. Surgical part is largely controlled or not controlled. It's actually, is managed by the LTSA very nicely, with a lot of surgical emphasis there. And we, our hepatologists, are all the time working in collaboration with the LTSI. I'm an integral part of that. But I thought that there was a thought which Ajay was telling me earlier, that there should be preceptorship. People who are getting trained in gastroenterology, hepatology, many DM centers, they don't have transplant structure training. And there was thought that they could be made to rotate in one of the centers, or heavy transplant centers, the hepatologists particularly, for 1 month period, and it would be, borne by the INSL per se, their cost of training and all, or the host center would bear that. But that's a good thought actually. I thought this is an interesting thing. Then we are also devising a lot of guidelines, national guidelines on liver transplantation. I'm a part of LTSI guideline committee, and I think that in some part there could be an LTSI INSL collaboration, and because we are again common members, there's no separation. And the last part, we have a lot of INSL task forces, like MSLD task force, hepatitis B task force, SC task force. And all these task forces, there is a component of liver transplant activity as to what should be done, in those patients. So here again, I think that SIG can like emphasize and take a sort of important step and contribute to it. These were a couple of my thoughts. May I request, the three experts, one by one, just pick up 1 or 2 points and spread, like how we can, again, I'm telling you, how we can contribute to the, INSL in this, from this SIG, how we can, contribute in the, development of liver transplant with these points in mind.
Let me talk about ideal timing and early referral for liver transplant in India. I'm not sure if it's a problem across the world, but certainly in India it is. You see so many patients, for example, of HCC who have been treated with lesser measures, and then they come with portal vein tumor thrombosis. I mean, yes. I would say of everything that you see in your liver clinic, half the patients have locally advanced or extrahepatic disease when they present to you. That's a lot. And obviously they have been seen by surgeons, gastroenterologists, hepatologists, interventional radiologists, or diagnostic radiologists, or even oncologists. So they've all been seen everywhere. And I think that it needs to be drilled down at all interrelated specialty level, that patients who have tumors bigger than 3 centimeters or multiple tumors with cirrhosis, they should be offered a transplant up front. There is just really no controversy there, right? For smaller lesions, yes. Lesser options of ablation, single lesions, less than 3 centimeter or especially less than 2 centimeter, fine. So what I'm saying is I don't need to spell out the criteria for transplantation here, but what I'm saying is the referral specifically of HCC patients is pretty late.
I would agree with you, yeah. How about the ACLF group, which is again a very big problem for us?
So ACLF group is a very, very big mixed bag, as you know, because it includes a lot of patients who have severe decompensation from having had alcoholic liver disease, which they know about already, and there is severe decompensation. Then there is severe acute alcoholic hepatitis, and then there is a clear ACLF the type of ACLF where you didn't really know there's much of a chronic disease and they present acutely. So there are these 3 types of just alcoholics, and then there are other classes. In general, I think they should be referred to a higher liver center straight away, as soon as such a patient presents. And really, all the criteria point to the golden period for transplantation being between day 5 and 10, around a week's time. And really, if you've gone on beyond 10 days, beyond 2 weeks, you really miss the bus for transplantation.
Yeah.
Could get well on their own with conservative treatment, that's good.
Right. Viniyendra?
Yes, so just taking it further, the ideal timing and referral. I think Dr. Sayan has touched on HCC. I think the more larger chunk is about Indian patient actually typically decides for a transplant when the ascites becomes refractory and uncontrollable. That's typical sarcopenic patient, and then they are having LVPs done 2-3 times a week. They've been on albumin therapy for a very long time, and that basically reflects on their peri-transplant outcome. And they take time to optimize to get up to the table, and then post-transplant they again spend a lot of money into it. So the whole thing is, if the timing gets right, I think that the cost of transplant actually can come down to them nearly half of it. Even if the hospital packages don't come down, but staying in a metro city, spending that much time before transplant and after transplant, it actually doubles the cost of the transplant. So that's my concern about the way, so the timing becomes very important for an Indian, in our context, that they are referred in time. Okay, I'm just going to pick up on the second point massively, and donor implication. I thought the reason I got this point was because this is a genetic and environmental problem. When we transplanting patient with NASH or MESLD, then most of the time the donors are wife, daughter, or son. And obviously with daughter, son, it is a genetic issue, and with wife, it is an environmental issue as well. So at that time, maybe they can get optimized and they can be fit to donate, but their long-term implication actually can be much more, and whether we should be careful in terms of selecting this type of donors for donor hepatectomy. I think that's a very big issue, and this is now 40%, 50% of cases coming through for transplant.
Correct. Dr. Nazia, what are your views on these points?
100% I agree. Coming back just to make a point, I think increased accessibility is not just to India, it's everywhere. And we also see the patients that they could have been referred a lot earlier for transplant. 100% I agree with the donors that undergo whatever diet or exercise or they go through to become a donor, and their long-term follow-up. And that's something that I am personally very, very passionate about that, and I think is a very big problem in our center. We start following up these donors at long-term, and majority of them gain their weight back, and their liver enzymes goes up by 4 or 5 years, and I honestly, I don't know what to do with them except offering them Ozempic and hoping for best. But I think it's something that should be done as a worldwide in centers that are performing living donors with previous muscle and undergo weight loss and come up as a worldwide approach to how to treat these donors and how to manage them so that they don't need a transplant themselves down the road.
Yeah, thank you very much. I think extremely important points, and we have heard the experts, and I'm sure we all have benefited from the views which we have been shared today. I think we'll have to bring this discussion to a close now, and I would thank all the attendees, panelists, the experts for their presence here. I will request all the three panelists to please come on the dais. We'll have a group photograph as a mark, which is a standard exercise we do every year. So please come on the stage. And I thank you all for your presence, and we look forward to more activity of the SIG task force and more productive and creative work ahead. Thank you very much.